Vai ter que continuar a sessão, não tem coffee break. Então, apesar do brilhantismo da primeira mesa, a gente vai ter uma mesa em seguida. Sobre isquemia de membros inferiores. E para essa sessão, eu convidaria para presidi-la o nosso querido decano, Dr. Antônio Vieira de Mello. Tudo bem? Onde é que eu sento aqui? Estou certo aqui? Então tá. Vou convidar também nosso querido companheiro de luta, grande diretor de publicações da sociedade, Dr. Júlio Peclar, para moderar essa mesa junto comigo. Vamos lá. Convidaria também para sentar à mesa os nossos apresentadores, Dr. Darren Schneider, Dr. Christian Bianchi, doutora Jade Iramoto, Dr. Bauer Sumpio, e a nossa coordenadora, doutora Cristiane Vieira. Muito bem, eu vou passar a palavra para o presidente, para ele dar as palavras iniciais dessa mesa, para a gente poder dar sequência aos trabalhos.
Muito obrigado, doutor Sérgio. Muito obrigado à Comissão Científica pela lembrança do meu nome. E como o doutor Sérgio falou, nós temos que andar rápido. O tema é da maior importância, continua em aberto, a revascularização do território femopoplíteo. E eu vou passar, então, a palavra para o moderador, doutor Meirelles, novamente.
Muito bem. Então, a gente vai dar início à nossa plenária. E a gente, então, vai começar esse assunto, que é de maior importância, com a palestra de Tecnologias para stents farmacológicos na artéria femoral superficial, com o Dr. Darren Schneider.
Thank you very much. It's really a pleasure to be here, and I'd like to thank the Society and the Program Committee for the invitation. These are my disclosures. When we talk about current superficial femoral artery treatment strategies, we have primarily both angioplasty and nitinol stents. Angioplasty has a high initial success rate, but up to a very high rate of restenosis within 1 year. Nitinol stents certainly have improved patency compared to traditional angioplasty. However, restenosis, in-stent restenosis, remains extremely common, occurring in at least 30% of patients, and treatment of restenosis and in-stent restenosis remains a challenging problem and is quite costly. When we look at restenosis, there are several mechanisms involved. There's elastic recoil of a vessel following dilatation, followed by negative arterial remodeling, and also neointimal hyperplasia with cell proliferation and matrix deposition. Now, we've effectively prevented a lot of the elastic recoil and negative arterial remodeling with nitinol stents, but the problem that's remained is the neointimal hyperplasia response, and this certainly is what we're talking about now, which would be the drug target with the drug-eluting technologies. Some early trials looking at drug-eluting stents for the femoral popliteal arteries were a little bit disappointing. These were the Sirocco and the Strides trials. Both of these were looking at the so-called limus drugs, sirolimus with the Sirocco trial, and everolimus, both of them with a polymer-based delivery system on the stent. And the bottom line was that there was really no improved outcome with the drug coating compared to bare metal stents. And here graphically are the life table results, both for the strides and the Sirocco at the bottom right on the screen. And the bottom line is that there was no difference in primary patency at 1 year with either the drug-eluting stents or the bare metal stents in either of these trials, so this is a little bit disappointing. Now, thinking about what went wrong with these trials, I mean, perhaps it was the wrong drugs. Maybe the IMUS drugs are not the solution. Was it the wrong dose, the wrong elution rate, the wrong stent, or was it the polymer issue? So there are a lot of variables at play here. Now, we have had some more encouraging results with a more recent drug-eluting stent platform. This is a Silver PTX drug-eluting stent. The stent was specifically designed for use in the SFA. Currently, this device, I know, is available here in Brazil and is also CE marked, and about 2 months ago became commercially available in the United States. It uses paclitaxel as opposed to sirolimus or the limus drugs, and there is no polymer or binder that's used, just the drug on the stent. The big study that looked at this, the pivotal trial, was the randomized trial, and it was in kind of an interesting trial design with both a primary and a secondary randomization. In the primary randomization, patients were randomized to either be treated with conventional angioplasty or the paclitaxel-coated Silver stent, Silver PTX. In those patients who had a technically unsuccessful angioplasty, there was then a subsequent or secondary randomization where patients were again randomized to be treated with the bare metal stent or the paclitaxel-coated stent. A lot of people are familiar with the results of this trial. This has clearly shown a beneficial effect, beneficial biological effect of the drug coating. And when you look at primary patency out to 24 months, there's a sustained benefit with the drug coating compared to the bare metal stents. One thing to keep in mind, however, is these are fairly short lesions with a mean lesion length of about 5 centimeters, and most of these are stenoses and not occlusions, so these were not very complex lesions that were treated. Nonetheless, this effect now in more recent data seems to be sustained even out to 3 years with a substantial patency benefit with the drug coating, sustained benefit due to paclitaxel, and there's a 53% reduction in restenosis with the drug-treated group. Now, one other technology that actually is becoming quite popular, and there's a lot of momentum behind this, particularly in Europe, is the potential advantage of using drug-coated balloons as opposed to implanting a stent. Some of the potential advantages are that there's a greater surface area for lesion coverage and delivery of drug. In a lot of these, there's a lack of polymer and no prolonged period of drug elution, so that may lead to less inflammation and more rapid re-endothelialization of the vessel. It eliminates the potential chronic mechanical injury from having an implantable stent in the femoral popliteal arteries, and of course this would be beneficial in the so-called no stent zones. There are vessel bifurcations in small vessels and perhaps within stent restenosis, and also balloons are pretty easy to use. With the drug-coated balloons, there's a single exposure of the drug, but this actually can result in sustained inhibition of cell proliferation. The drug that's been used in most of these balloon approaches is paclitaxel. It's a very hydrophobic substance. It penetrates the vessel wall and is deposited in the vessel wall. It's usually combined on the balloon surface with some sort of incipient to enhance delivery. The most commonly used ones have been urea and iopromide. And paclitaxel itself selectively inhibits vascular smooth muscle cell proliferation and also some matrix production and deposition. Now, some of these trials started a number of years ago. The initial proof of concept trial in patients was the Thunder trial. This was published in the New England Journal of Medicine back in 2008. There were 150 patients that were randomized. These were femoral popliteal lesions, relatively short, about 7 centimeters, and patients received either a paclitaxel-coated balloon angioplasty or angioplasty with an uncoated balloon with or without paclitaxel included in the IV contrast material. And in the results, there was angiographic follow-up showing decreased target lesion revascularization. There was reduced restenosis, but there was no difference in primary patency at 6 months. In clinical follow-up, there is no difference between the treated groups, and all groups similarly improved their Rutherford class and ABIs, but this is the first trial to show a potential biological benefit that was sustained with a single administration of drug using a drug-coated balloon. The subsequent follow-up trial was a FEMPAC trial that also showed significantly decreased late lumen loss, and that's been the common theme and the endpoint for these trials, decreased target lesion revascularization and decreased rates of restenosis at 6 months with the drug-coated balloon as opposed to the plain balloon. There was also significant or better improvement in Rutherford class, but there was no difference in ABI in this trial. Now, there's been several randomized trials that have now been completed. I spoke already about Thunder and FEMPAC, but also Levant and Pacifier have also shown similar benefits. Usually the primary outcome has been late lumen loss at 6 and 12 months. These have used the Codavance, the Moxie, and the Impact balloons that are now commercially available outside of the US. And here, graphically represented is 6-month late lumen loss, and there's significant benefit here in these blue columns representing the drug-coated balloons. Again, keep in mind these have been short lesions, all about 6 to 8 centimeters in length, and a small percentage of occlusions. Most of them are stenoses in these trials. The Levant 2 trial was the first trial conducted in the United States. And this trial has recently completed enrollment, and results will be forthcoming, hopefully, in the next year. And currently, this is a very fast-moving field. There's over 35 registered drug-coated balloon trials that are actively enrolling patients. To conclude, certainly the drug-eluting stents and the drug-coated balloon technology with paclitaxel have shown a strong biological effect on the inhibition of neointimal hyperplasia, may improve patency, and have been shown to be safe in the treatment of superficial femoral artery lesions. It's still unclear which lesions are better treated with either a stent or a drug-coated balloon. Stents may be better for calcified and longer lesions or occlusions, whereas the drug-coated balloons may be better suited for treatment of in-stent restenosis, small vessels, and I'm particularly excited about the promise in tibial vessels and bifurcations. These certainly do add cost, so it's going to be important to determine which patients and which lesions will benefit the most from treatment with drug-eluting stents or drug-coated balloons, and this is not known. Certainly when we look at cost, the drug-coated balloons can be used only once, so if you treat a long lesion, you may need to use several of these balloons, and the drug-eluting stents still are not currently available in long lengths. So further studies are definitely necessary. We need to directly compare drug-eluting stents to drug-coated balloons, and we also need to look at both of these in real-world lesions. Thank you very much.